Okay?
Yes, I got the permission to record, guys. Okay.
Buenos dias. Yo soy el Dr. Maíz. Mucho gusto, mucho susto. No se preocupe, no me duele. Those are all my good ones, you know.
that was the funny one.
Yeah.
No me
Okay. We're going to talk about electrosurgery, which I was just relating that there are all kinds of restrictions on laser and stuff, and none on electrical use in the OR, yet they are almost identical in the damage that could do. In fact, probably, I'm not aware of deaths. I don't think I've ever seen a death from a laser, but I've definitely seen them from this, from electrosurgery. You will probably see them in your career. So part of what I want to do is to educate you about really what's going on with this, okay? In terms of understanding a little bit about how the energy is used, what kind of effect you can expect, and to have you think logically about that. So one of the problems, this is an example of the types of things that I like to talk about with you guys, because it's not generally taught. It's just sort of, they toss you in the pool and there you are. And because of that, people use a lot of terminology and stuff which really isn't correct, non-specific, etc. And what's the most common thing people call the process of using electricity in the operating room? Do you know?
Bovie?
Yeah, Bovie. Okay. So, and what does that tell you? Nothing, really. I mean, it's somebody's name. And in fact, you won't find that name anywhere on any equipment or anything like that. And I believe, from what I understand, the reason for that is that this guy Bovie never got the patent or anything like that. I think it was gotten by Harvard or somebody else. And another thing people call this, what's the second most common thing it's called?
Called ligature.
No,
Bovie.
just by general use. Like when you put in an operative report that you used
Electrocautery.
cautery, okay?
Cautery, yeah.
So cautery actually is the process of burning tissue, okay? So before this technology was available, that's all that there was. So I always imagine the Civil War, somebody needs an amputation, there's a artery that the bleeding needs to be stopped. Now they had some options with cotton and silver wire and stuff like that, but they could also take a hot iron out of the fire and cauterize it, okay? And in fact, cautery is still done, but it's done on the backsides of cattle, and it leaves a big scar, and that's intentional. But you can see that, and why is that scar formed?
Name to identify that it belongs to someone.
Well, that's why they do it, but why does the scar happen?
Because you're burning.
Yeah, because you're burning and you're not containing the heat very well, and you're causing a lot of damage, okay? And so basically you've killed tissue and it regrows with scar. And so if you can imagine trying to do pituitary surgery that way, what would be some of the possible complications?
That they would have like pituitary dysfunctions, they could have issues with ovulation, issues with
So let's say our goal is to remove the pituitary. So we were expecting those things. But what would the collateral damage be?
I guess you could damage the structures in your body.
Which are?
The hypothalamus
And?
Optic nerve.
Yes.
Optic nerve.
Yes. So you'll blind people, okay? And worse, it's the bottom of the brain and stuff like that. Okay, so this technology came about and was popularized because it allows a more precise use of energy, and it allowed a guy named Cushing to work with a guy named Bovie, which led to being able to do pituitary surgery, which Cushing did. And Bovie sort of popularized this in the US, although the technology was invented by French people whose names I don't know. Jacques and Pierre or something, or Matt and Marie, I don't know who it was, could have been anybody. Yeah. Jennifer and 2M Jennifer. Okay, so here we go. So what is this now? So first thing I need to do is plug it in. So that tells you something about our starting point. So what is it that comes out of the wall in terms of energy? Do you know?
Electricity?
Yeah, that's true. It is electricity. How can you describe the electricity for?
Okay.
What kinds of electricity are there?
AC, DC.
Yeah, AC and DC. Okay. So what does that mean? What's AC?
Alternating.
And DC?
It's direct.
Yeah. So with
Yeah.
direct current, the electrons start here and they go there. It's one way, kind of like the ants walking to the refrigerator or something like that. One way. And I guess then they walk back, but you know, we won't go into that part. Just going one way, okay? And alternating, it's doing this. It's sort of an oscillation. So if you're one electron, it gets very boring. You're just going back and forth, you know, like a guard walking back and forth across, okay? And oscillates like that. Now, this is a little interesting because direct current was Edison's thing, and alternating current was Tesla's thing. If Edison had won the battle, in order to use electricity the way we do, there'd need to be a power plant basically on every block. Because with this, you know, long progression like this, you get some sort of attrition all along the way, and it ends up getting weaker and weaker. Whereas with Tesla's thing, that doesn't happen, okay? So that's why we have our power plants. We don't even know where they are sometimes, and you know, not on every block, okay? So yes, it's alternating current. And what that means is if you draw it as a sine wave, when it's on one side of the line, it's going, let's say, to the left, the other side, it's going to the right. And it oscillates at a frequency. Do you know what the frequency is? Do you ever see things written for, like, what goes, it says 120 volts, and what else does it say? Cycles. What is it usually? It's like 60,
Oh.
okay? 60 cycles or hertz, the same thing.
Okay.
Okay, that means 60 times in a second, this oscillates, okay? Now, if we're playing charades, you ever play charades?
A few times.
Okay, so I want you to act out what happens if I took the output of the wall, and put one on each side of you. Act it out. That's what's gonna happen?
I don't know, that's what I guess.
You never got a shock
Oh, it's a shock?
from the wall?
If you put one on each side, then doesn't it like stabilize?
Well, no. If let's say
Zappy.
you're working on that and all of a sudden it hits you, electricity hits you, what happens? There you go, what's going on? What's this?
It's like a rigidity
Because
of the like depolarization.
yeah,
of the
neuromuscular
muscles.
depolarization, okay? So 60 cycles will cause neuromuscular polarization. And what the French figured out was that if you changed it from tens of cycles per second to thousands or millions, you don't get the depolarization. You don't get neuromuscular depolarization, okay? And kilohertz, have you ever heard kilohertz before or seen it anywhere? And megahertz?
Yeah.
Yeah, where?
I'm not sure where though.
In your car?
And the radio
Music, like a
stations.
Radio.
Mm.
So this is AM and this is FM. Okay, you ever hear a radio frequency?
Oh, yeah.
That's what radio frequency is. So now this oscillation is so fast that it's not interpretable by the nerves, and we can use it to deliver energy safely without electrocuting patients. Okay? And it's not just the tetany of the muscles and the shaking, but you can also get depolarization in the heart, and that's why, you know, electricity has been used for like the electric chair and stuff like that, not to burn people up, just to stop their heart. Okay? All right, so now we've got this, which in, I'm going to say layperson terms, is called a bovie. You won't see that word on there as I explained to you. What you do see is a thing that says electrosurgical generator. And it's got a brand name here, and that's not, the brand name isn't that important. It's also called an electrosurgical unit or an ESU. And if you read, generally you'll see this either in MIS or occasionally Eurogyne kind of people writing about energy use. They'll refer to ESU, and they won't generally use the people. In general, people that know what they're talking about are not going to say things like electrocautery, okay? Because we're not doing cautery, but it does slip through. It's sort of a sloppy kind of term. So when you have a unit like this one, you have to turn it on. And this is not a recent generation of these. The more modern they are, the longer they take to start up. Like it has to start Windows or something like that, or who knows what, you know. So this is going to start and go through a sort of a self-check, and then it's going to alarm. There's the alarm of the red, okay? So we now have two connections we have to make. What's this called?
Grounding pad.
And what's this called? The bovie, right?
Bovie, that's the
There
instrument.
you go, perfect. So actually, if you think about it, the electricity goes from one place to another, right? Back and forth between two places. Grounding means it goes into the ground. There is no grounding with this, okay? This is not a grounding pad. These are two electrodes. Every electron that goes through here goes through here. I mean, for each one that goes one way, it goes the other way, okay? Otherwise, you'd have loss of current and stuff like that. And you wouldn't want it grounded because then you can't control sort of where it's going. Normally what you do is you place these two electrodes close together. So if you're working here, you're gonna have it like on the back or the thigh or somewhere close. You wouldn't like put it here and be working on the toe, because then you have to go all the way through the body, and you know there's more chance of a leak and stuff like that. So in fact, you see it does not say grounding pad, although every nurse will refer to this as a grounding pad. It says return electrode. Now I like the word electrode, and this should also be called an electrode, but the return implies that we're working with direct current. But you know, so it's not perfect, but it is a electrode. Now this is also an electrode, and here they're calling it electrosurgical pencil. That's better than saying a bovie, but and yeah, a pencil, because you can kind of do this. But really, these are both just electrodes. Now, if we look at them, there's really only one difference when you really get down to it. Okay?
So are those the two poles of the alternating current?
Yeah,
Okay.
it's
Then what
just
about,
like the two sides here.
But then what about the side that is connected into the machine?
So hold on for a second. Okay, so remember the electrons are coming out of the wall and they're going back and forth. And then they're going through the machine, and now they're going back and forth faster. And then they're here.
Oh, I see.
It's just straight out, okay? Thank you. Now, there is some technology built into this that I'm going to explain in a second. For one thing, you have some choice about what's called a waveform. So when you press this yellow button, which is labeled cut, you get essentially a pure sine wave like this. And when you press this other button, which is labeled coag, you're going to get a different waveform that I'll talk about in a minute. And that means this isn't just going to be a single pole here, because it has to tell the machine what to do, okay? This is also not a single pole, because instead of being just one electrode here, you'll see there are two. And there's a reason for that, and this is called a return electrode monitor. So what does that mean? So first of all, when you set these up, you'll see this has no, it's symmetrical here. So you can just plug it in without thinking about it, and it'll go where it says patient. Or it may say, you'll see like REM or something near here. Not the band, but return electrode monitor. And you see how it alarmed when I put it in there? That's because it's detecting no conduction across here. Okay? Now, I said there was one difference between these two electrodes. What is it?
Is it because there's two?
Not that.
No.
Because remember, this used to be just a single plate. You'll still see that in Africa and other places. So this could be a single plate. It's just the surface area. Okay, so this surface area is pretty small, and this is much, much bigger. And what that allows, if the surface areas were the same, every tissue effect I got here, I'd get back there as well. In the past, when this was a single plate, if it fell off, as it peels back, it starts to concentrate the energy more and more until you burn, and you could burn the buttock off or something like that. So having the two plates is a safety against that complication, okay? So watch what happens now. I'm gonna take our patient here. We had some spam volunteer, but it was all too late for the spam. I don't even know if spam would work. It's got too much fat in it, probably.
I don't know.
Yeah, who knows? Okay, this is
It's
just,
probably cheaper than the steak.
No way. Spam is expensive.
yeah?
Really? I don't know. It depends where you go. Yeah.
Okay, so watch what happens when I put,
Ah.
see how it turned green? Okay, now watch what happens. Just imagine this peeling off. See how it alarmed? Because there's no conduction. Now it's happy again. When it's alarming, you can't activate it. Okay? So it's a fail-safe thing. That's called a return electrode monitor. Now the pencil, this is not symmetrical, so you have to look at what you're doing when you put it in. And this is often going to say bipolar, monopolar, and there'll be more modern ones will have ligature and stuff. And you just see how it's going to go and then just push it in. Okay? So really all electrosurgery is bipolar. Here's the two poles. One there, one there. What we mean when we refer to bipolar is instead of this, you have the other electrode on the same instrument, in which case you don't need any pad, okay? So when you're using bipolar energy, you don't need a
Pad.
return electrode,
Return electrode.
okay? And it's not grounding because that's kind of like lightning strikes. Where does it strike? Wherever it's easiest. You don't want that. You want to control where the energy is going to go, okay? Okay, so now I mentioned there were two waveforms. So one waveform is just the sine wave of energy unmodulated. It's not changed at all. And the other waveform is modulated. So this is the cut, and this is the coag. And this is voltage. Okay. Voltage, okay? And this is time. So, I want you to think now, we're going to think a little bit about cooking. Let's see what's going on here. Okay. there are two ways we can think about cooking the steak. One way is we're gonna put it in a pan and we're gonna turn the electricity on the coil. Let's say on medium or something, and just sort of let it sit there, okay? Over time, it'll cook the meat, right? This way, instead of the electricity, well, let's say it was a gas stove. So we put the gas on, like medium-low, this is in a pan, sitting there cooking. The other way, we're gonna take a gas flame, and we're gonna, and then stop. And the flame is gonna go for about less than 5% of the cycle time. So for every second we get a flame, we have 20 seconds of nothing. Okay? So what's going to be the difference in how these things cook? What do you think, Jordan?
I think that the blast is going to make it cook less evenly.
Say more.
Like the outside will be cooked like to a greater degree than
Yeah.
the inside.
And when you say a greater degree,
like it'll be more like charred.
it could even be charred, right?
Yeah.
It could be black and the inside could be
Raw.
completely, exactly, okay. That's a very important thing to understand. And the reason that happens is because of the cooling, okay? So when you cook let's say you're making flan, when does it get firm?
When you put it in the refrigerator.
When you cool it, okay? So to get coagulation, you need cooling. This is cooling. That's why this is coagulation, okay? So that's an important thing to understand. Okay, so now let's see what the energy can do. We now have two factors I told you about, and basically to understand this, you basically need to get this 2x2 table here. I'll try to write it. So this is going to be no touch, no contact, contact. And this is going to be the cut and the coag. Okay? Contact and no contact. If I allow the electricity to spark, the electricity is focused in the width of a spark. How many sparks fit on the head of a pin or in the? A lot, there you go. So it's a pretty small area, right? Whereas if I touch, now I know, it's a measurable like surface area that I can see. So it's much bigger than a spark. And what that's going to mean is a difference in focusing the energy really concentrated or having it more diffuse, okay? If I focus the energy to the maximum point by sparking it, and I use the cutting waveform, which is giving current all the time, the energy goes to the cells, it heats the water inside the cells to the boiling point very quickly, the cells burst and steam comes off, okay? And that's called vaporization. I'm just gonna put a big V here, V for vaporization. It's as though we cut this with a knife because the steam carries the heat away. It protects the surrounding tissue. And you're not going through the point where you are denaturing proteins and drying out the tissue and then getting the char as it, again and again you hit it, it becomes elemental carbon, okay? So I'm gonna push the cutting button before I touch the tissue. So it's on. Now I'm gonna draw it through the tissue. And that's vaporization. Would you get some gloves? Here, just wear the, okay, yeah, you guys take whatever you want there. And just look inside this,
Ooh.
okay? Is that cooked? Or is that going back to the kitchen? Assuming we're not in some, So there's some fat there, but look at this side.
That's cooked.
You think that's cooked?
I don't know. I don't eat steak.
Okay,
Looks medium raw.
Looks like it's
Medium.
cooked.
okay, here. Okay, open that up and see what that looks like. Does it look any different? Again, don't look at the fat, there's too much fat
No,
on
it
this.
looks raw.
Okay, well, watch now. So now I'm gonna do in contact, and I'm gonna apply the cutting. Now what's gonna happen now is it doesn't heat up as fast. So what happens is proteins denature, some of the water seeps out of the cells shrink, and that's called desiccation, like drying out.
Is that contact?
You're right, thank you. You're always keeping an eye on me. I like that, that's good, because you don't know what I might tell you. Okay, ready? So on. Okay, now to me, that's starting to look like, see this stuff? It's starting to look a little more cooked. If you compare with this. See the difference?
Oh, yeah.
Okay? All right. Let's talk about going through the abdominal wall. Let's say we cut the skin with a knife. Now we're going to go through the fat layer and the fascia. What's the goal here, really? We want to cut the tissue. We want to stop any significant bleeding. And we want to avoid destroying the tissue, cutting off all the blood flow and stuff, because you'll increase wound infection, poor healing, and so on. So by using the cutting, not in contact, to vaporize, it's similar to like a knife. If we get a significant bleeder, we can put a hemostat on it, touch this to the hemostat, and push cutting. And that will desiccate the blood vessel, and it'll stop bleeding, okay? Without a lot of thermal spread, it's just very superficial, and without destroying tissue, okay? Now, coag, just like Jason said, Jordan. This med student 07 kind of gets me. Med student 7, 007. McDonald, Jordan McDonald. Okay, just like he said, what's his name? You just blast the outside and then let it cool and blast it again. So there are two consequences. One is you just keep hitting the same tissue again and again with energy, which is gonna eventually break it down to charcoal. And number two, when you're letting it cool, the heat that you put there is going to go to the surrounding tissue, so you're going to get lateral damage, okay? The first way to use this, that's an F. F as in fun, okay? It's called fulguration. So remember sparking, okay? So I'm going to activate now the coag waveform and start to draw it through the tissue. And when you do this yourself, you'll clearly feel there's a difference happening here. And if you touch that, it's going to start to feel
Much more cooked.
more cooked, more like a scar or something. Not that it's scarred, but there is a gradient here, okay? But this is very superficial. If you look here, you can see it's probably just a few millimeters thick, and then underneath there's nothing. See that? Okay? Now the last thing is the coag in contact. And I'm going to put a sort of quote around coagulation, because this is sort of, if anything, it's an ineffective coagulation. Now, just going back to sort of my premise at the beginning here, was that people basically don't know what they're doing with this, okay? So far I've told you, you can cut tissue, you can stop discrete bleeding, and now if you have a raw surface, you can fulgurate it. Let's say it was in the letter E, like Berenma. I could do that, no problem, okay? So, and this may not be an E, it may be like the base of a loop excision or something else, okay? What else would I want to do with energy?
Nothing.
Nothing. Now, let's go down to the operating room. And if you watched how people use this, most of them use coag in contact. And it's really the only one here that shouldn't be used. Okay? And I'm trying to explain why. So first of all, let's see what that does. So now we're in contact. Okay, and this is going to be sort of the most cooked, but again, it's sort of superficial. Now, just to make a point, let's think about maybe some ways we might be able to use this. So, we talked about ligature. Okay, do you know what a ligature is?
The clamp that cuts.
It
With
cuts.
electricity.
What's the electricity do? Does it cut with the electricity, or does it cut with a metal blade?
Oh, I guess the electricity like cauterizes and then it cuts.
Okay, so I'm just going to point out the word cauterize, okay? So that's on my, just kind of raise my ears a little bit, okay? But I think you're trying to say is the electricity will be used to close the blood vessels so that when you cut it, it doesn't bleed, okay? Now, in that instrument, it's a bipolar instrument in that both electrodes are on the same instrument. So you don't need one of these return electrodes for a ligature, okay? What waveform should pass through that?
Well, I guess the first part is coagulation.
So, first of all, are we in contact or can we spark with a ligature?
We're in contact.
We're in
You
contact, so we
close
can take
first.
away these. So you have a choice of cutting or coag. Which do you want to do?
Well, I thought we just said we should never do that.
Right, that's the,
So-
okay? But what do you want to do?
I mean, that's what I want to do. in
That's what you
theory.
want to do. So watch what happens, okay? And I'm gonna, yeah. So, I'm going to start with coag. I'm gonna just apply this and I'm gonna count to 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay, see what that did? See how deep it went?
Mm-hmm.
Cutting, ready? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Oh,
See the difference? Okay. When you get the ligature in the operating room, what settings do you put it on? Who's used a ligature? What settings?
You don't.
What settings?
Yeah. you should-
No, what settings?
Yeah, you
Why can't you put any settings? What setting would the doctors have put it on?
Coag.
Coag.
yeah.
And what would happen?
Yeah.
Jordan, I keep saying Jason. Why am I thinking Jason?
I
You
don't
just
know.
start calling you Dr. P.
Dr.
Or
J.
Dr. Carrot.
How about JM?
That's fine.
JM. You can call me.
Dr. Mais.
I used to go by K Money with some. That was my DJ name back. In the day. What would they have used? They would have used coag, and so they would put the ligature on. They would press coag. The current would stop going. They would put the blade through, and what would they find?
That it like didn't separate the tissue all the way.
Bleeding.
It would bleed
Yeah.
because the vessel is in the middle.
Oh, I see.
Okay, and what would they do with the ligature then?
Use it again.
They would never use it again. It would be in here.
Garbage.
Okay.
Oh.
So they realized, somebody was smart enough to realize that, they just took the control away from the doctor. So what do you think actually goes through it?
Goes through.
What waveform did the engineers put in it?
Oh, the sign.
But yeah, it's cutting. It's the unmodulated, for the most part. There's a little bit of coag. And the reason you can tell there's a little coag, and that they vary from ligature, gyrus, different brand names, is the amount of lateral spread is different. The more lateral spread, the more coag they're putting in there, okay? So here's another thing. electricity was used to do sterilization procedures. So you'd grasp a tube, fallopian tube, pass electricity through it, and with the idea of destroying the lumen, okay? And there's a study called the CREST study where they looked at failures. And they found, they were looking actually at monopolar with the grasper and with this versus bipolar, both electrodes on the same, but the waveforms were different. Okay, one of them was cutting and one was coag. So which had more sterilization failures, the cutting or the coag?
The coag.
Right, because you got carne asada on the outside, or ahi tuna, or whatever you want to think of it as. The inside, it's probably not terrific, and it may be, but it's patent. So maybe you get an ectopic or something which isn't the best news. Okay. So the last thing here. I'll just quickly do this because I want to be downstairs at 10 of. Okay. So a loop excision is where we take a wire loop to remove dysplasia from the cervix. And it's both a diagnostic and therapeutic procedure. So we don't want to just destroy the tissue. If you wanted to do that, you could vaporize it with a laser, okay? And it would be, like we talked about yesterday, you want a high concentration of energy, so the tissue boils, steam carries the heat away, and the tissue disappears, okay? So here, instead, we want to get a sample that will be something the pathologist can read. So we're going to use the cutting, not in contact. I'm going to turn it on, go into the tissue up to the bar. I'm going to move, and then this would be from below up and come out. Now, if I take this out and you look at that, it really isn't cooked to any significant degree. Your taste.
You're such a good fellow.
Hawaiians will eat anything.
It's so
Anything that comes out of a can.
Did this come out of a can?
No.
I don't think so.
Came out of Safeway.
No, I can't do that now.
Okay, now here's what I often see learners do. So they start, they go in, and you get about here, and then they take their finger off. So where are we now on our graph? On our box.
Now you get in the lower
Now we're here.
contact.
So I'm going to try to start again, and nothing happened right away. Do you see that? Now it's going to happen, and you'll see steam is going to start to form because this tissue has a lot more water in it than the cervix does. But in a cervix, you'll now be stuck doing desiccation. And what we should see here now is you start to see some thermal artifact on the second part. And if you give that to the pathologist, they're going to tell you carne asada. And I can't tell you anything about the margins and stuff. We don't want that. We want to know. Okay? Now, at the base of this, let's say it's oozing. There's not one particular vessel. Now I can use some coag. Let it spark. I'm just sort of painting. You see the sparks? And that's desiccation. Not desiccation, that's fulguration. Okay. Now, so far, working on the abdominal wall, working on the cervix and stuff like that, there's limited amounts of harm you can do. You can destroy tissue you don't need to destroy. You do that on the cervix, people get stenosis and then dysmenorrhea. Abdominal wall could be a wound infection or hernia or that kind of a thing. But when you start to go into into laparoscopic use of energy, that's where you start to get deaths and stuff. And the reason is you could have direct thermal injuries where, let's say, I think this is the tube, but it's really the intestine, and I do something to it, okay? Or I could have an indirect one where I've got a grasper, I'm holding something, this touches the grasper and it's touching something else. Or I could have it spark someplace. And then there's another one which is a little more complicated, which I'll tell you about if we have time. But One of the characteristics of coag compared to cutting, there were three differences. What are the three differences? One, there's a big rest cycle. Number two, high voltage. Okay? And then just the amount of current is a lot less. So, there's a red sign on the door. Instead of flammable anesthetics, suppose it said high voltage. Jordan, what's the next word?
High voltage
Next word comes, just say it.
prohibited.
Not prohibited. Well, it could be high voltage prohibited, but high voltage, it's telling you
Like there's a high voltage
Stay away.
procedure happening in
danger,
the yeah.
right?
Don't come in.
Does that make sense? It would say danger, high voltage. I mean, you see those words together. Okay, so really, this is high voltage. They've got this nice blue. It looks kind of
Friendly,
mellow
friendly.
and stuff, but it really should be like with a cap on top of it and a skull and crossbones, and only use warning high voltage, because if you cut the bowel with a scalpel, the patient has spillage of the intestinal contents with bacteria. They're going to get sick within a day or two. If you burn the bowel, it can take up to 10 days or so before it leaks, at which point the patient is more remote from the operation. People don't think about what might be going on. By the time they get to the emergency room, they've usually been given laxatives and other sorts of stuff, and they're coming in now with usually septic RDS, which is a 50-50 survival thing. So this happens, okay? So one of the ways to avoid it is not to use high voltage. It's just much safer. So tomorrow, when we do our sacrocolpopexy, we're going to be cutting tissue, we're going to be stopping bleeding, and we're only going to use the cut. We're not going to use coag. I won't even have it set up. We'll use a ligature. That also won't use coag. So the whole operation basically, unless there's some unusual complication, we will do with cutting. So what I want you to do now is very quickly, one at a time, we will go through the four things. So cutting not in contact, vaporization. Cutting in contact, desiccation. And do it like 1 and 2 and like that, okay? And leave room for each other. Why don't we start here? Oh, start here. Start here. Who's ready? Okay? So cutting not in contact, vaporization. Go. 1. Don't be afraid to let it go in the tissue. Now cutting in contact, desiccation. Feel the difference?
Mm-hmm.
Coag not in contact. Try to pull it through the tissue. Fulguration. And now coag in contact, and this is like that who must not be named or something. I don't know what to call that, but would you like that done on you
No, thank you.
for your C-section or whatever? Do me a favor, stop for a second. Don't hold, don't do that, okay? Yeah.
Thank you.
Okay. Cutting, not in contact, vaporization. Just pull it through. Good. Try to make this next one the same amount of time. Yep. You got to touch first, and now on. Okay? Now, you may think, oh, I'm touching it first, but then I go into the tissue. So doesn't it change from vaporization, non-contact to contact? And the reason is no, because the steam surrounds the electrode and allows the sparking to continue.
So it continues.
Okay?
Okay, and now I do coag but don't touch.
Yep.
Yeah, this is not the same. And then touch and
You could just feel it.
yeah, it
Nothing
doesn't
good
pull
is
through.
happening there. Now let's say you did a supracervical hyst and you want to destroy the endocervix and maybe a little bit of lower uterine segment that you might have left behind. You're going to do that with electricity. What should you do?
The fulgurate, right?
Okay, so What's the nature of the type of tissue that we're trying to destroy?
It's glandular.
Glands.
Yeah.
And what's the nature of fulguration?
Oh, yeah.
Oh, it's just surface
Same
level.
Yeah, so that's not gonna do it.
Desiccate it.
Yes, you have to desiccate it. Remember what I showed you on the side here? So the coag, it's gonna look bad, but it's gonna be superficial.
What did you mean when you said you were going to set it up on Friday to have no coag?
There's a foot control when we do laparoscopy for the handheld, like the scissors and other things that we're gonna use electricity on. And the foot pedal will only be the one for the
Cutting.
cutting.
I
Well, okay, so I could choose cutting or coag, but you're right. I'm just gonna put my foot on the cutting, or general, or whoever.
Okay.
Okay, now let's just really quickly here. Pull. Here. Okay, quick, do a leap. So I like to do them from below up, so just imagine that this is the bottom, this is the top, so you're gonna come in this way. So on, go in, up to the bar, now come towards me, and now come up. Good. Now go in without activating it, go halfway, the same way you went, and pull it towards you. Yeah. Okay, there you go. Now try doing that with coag to see what happens.
Getting resistance here.
Yeah, and that's just totally going to destroy the tissue. Okay?
Didn't want-
Next, who needs to do a leap?
I'm gonna know when to do leap. I will never be doing a leap on a pregnant person.
Good. Right. Now take that out, and I think you're going to see, hold it to the side. Do you see how it's a little bit like this?
Yeah, it's kind of.
Now let me show you something. Put it down and listen to me, okay? Go over there. Ready? You're going to start again. I'm going to say you go down, go towards me, come out. Don't do it until I say. Okay, ready? Go down,
With in
on,
contact with him.
cut. Come towards me. Wait and come out. Okay, now take it out. So you have to wait for the loop to catch up with you on the last part. That's why you got the V,
Gotcha.
because it takes the loop a while, especially in the cervix. Okay? I promised I'd be down there at 10 of.